Good morning. Hopefully I will do these slides some justice for Dave. I do miss him at the moment. So these are Dave's disclosures. Mine are that I currently work for Cargill, and in the past 5 years I've also held a role at Tate & Lyle previously. So many of us have seen this particular pyramid, which is kind of an evidence-based ranking, if you will, where in vitro test tube research kind of formulates the bottom of the pyramid. It's used foundationally in a lot of experiments to start and drive hypotheses, all the way to the top with systematic reviews and meta-analysis, which incorporate all of the evidence below it. So you can see that there's multiple levels for this bracketing, if you will, of strength of information, whereas the randomized controlled trials at the top can demonstrate things or show that something is able to do something compared to a control, whereas controlled longitudinal studies may cover that it is likely that something happens. Uncontrolled longitudinal studies can give you some signs. Expert opinions and the cross-sectional studies might give you some inkling of ideas of where things are, and that from the bottom to the top, you go from a generation of hypothesis, which has more heavy opportunity for bias, and then the randomized controlled studies are more to establish causality, and that has lower levels of bias, although good design still comes into play. One thing that Dave wanted to try to get across was the use of causal language in observational studies in obesity and nutrition. So if you look across some journals here, this was summarized in 2010. Journals like the American Journal of Clinical Nutrition, AJCN, is at the top. Then they list the Journal of Nutrition, Obesity, and the International Journal of Obesity here with their respective abbreviations. You can see the number of articles that are there that were assessed and the numbers with causal language, and where you find that, that by the journal, by the type of design, whether it's a case control cohort or cross-sectional study, you can see there's a lot of studies that are using causal language. Whether or not that manuscript primary result was using a p-value. The good news is a lot of people are relying on significant p-values of 0.05 or greater that will be considered significant, whereas the non-significance being dropped below that. So that's a good thing. So we can say that that's a substantial way to start as long as you're doing good statistics. And then there's been concerns around industry funding, and for industry funding that was present versus not, and here they have the no's. Out of 419 articles reviewed, 125 of those were presented with causal language, and those that were funded by industry, there was 42 articles with only 15 showing causal language. So, and that was a non-significant source of any kind of bias there. So just kind of keeping all of these things in context around use of causal language. There are limitations to human nutrition studies. Randomized controlled trials are rare for chronic diseases, and results have been null. Observational studies tend to dominate. Most rely on potentially biased self-reports. Food frequency questionnaires are semi-quantitative. Validation is simply a correlation against 24-hour recall, often not valid for an energy or protein. And we were discussing this actually this morning. Also not considering the differences across a particular food category and the differences that may lie in there. When nutrients are divided by invalid energy, then there's no correlation or conclusion possible. So is this why diet patterns are replacing nutrients in health epidemiology? Because it's very difficult to get to the precision needed. Baseline intake does not predict long-term diet, and variability in nutrient contents of foods is often ignored. So if you're eating a yogurt, is that a high protein type yogurt? Is it a Greek yogurt, or is it more of one of those skinny yogurts, a light Yoplait, for example? But yet they all get categorized as yogurt. Grade. This is a kind of a newer concept, I guess you could say, thanks to Gordon Guyatt. Grading of recommendations, assessment, development, and evaluation. Dr. Guyatt proposed an emerging consensus on rating quality of evidence and strength of recommendations, which was published in 2008, along with 4 other papers at the same time. He's had several since then where that's been applied to WHO recommendations, for example. There's a clear separation between the quality of the evidence and the strength of the recommendations. Explicit criteria for upgrading and downgrading quality of evidence ratings. And randomized controlled trials begin as high quality and observational studies as low quality. So going back to where they fall on that pyramid. And you can look up their work here at the website that Dr. Klurfeld has provided. So a little bit more detail about the grade guidance and how the rating is done. So certainty of the evidence is rated for each outcome across studies, randomized control trials with a high rating, observational studies again with a low rating. Then the rating is modified downward or upward based upon the following types of criteria. So study limitations will downgrade the study level in precision in measurement and consistency of the results. Things that can, and then where there's a bias likely, can fall into downward grading. You can also improve the score of your study if you have a large magnitude of effect, so you can clearly see a difference. Dose response is observed, so having multiple doses in a clinical trial is a good idea. Confounders likely minimize the effect, so those things that are adjusted for. And then final rating for each outcome is rated as high, moderate, or low. And so basically this is just another opportunity for how we need to have more information around studies using randomized controlled trials. And having grade, it provides us a standard of evidence. So traditional DRIs versus DRIs for chronic disease. And so this is something that has a little bit touched on earlier. But DRIs, traditional DRIs, are essential for nutrients and are needed because of their deficiencies and toxicities. They will affect everyone if intake is inadequate. They are caused by one nutrient, and they are prevented by nutritional interventions. For example, zinc. Zinc deficiency has been identified since the 1920s, and addition of zinc has been shown to reverse some of the ill effects. Chronic disease DRIs are not warranted unless sufficient evidence exists because risk to adequate COVID variations by individuals. So the chronic disease can be caused by multiple etiologies. Chronic disease are often related to many risk factors, genetic, environmental, and nutritional interventions will only partially ameliorate the risk of chronic disease. For example, the development of colon cancer and the relationship with fiber. So does increasing your fiber intake help decrease that risk of reoccurrence? So there's a paper here that he wanted to draw attention to, and that's the association between dietary factors and mortality from heart disease, stroke, and type 2 diabetes in the United States. This was published just a few years ago. And one thing that came out of this paper was the following graph, which has a list of 10 dietary factors, and cumulatively, 45% of the deaths were associated with suboptimal intake, according to the abstract. But this figure here claims that those deaths are attributable to dietary habits. And you can see high sodium is at the top here, low carbs. So then high processed foods. So there's a lot of things that can kind of lead into this low fruit and low vegetable intake, but a lot of times people focus on the top of the graph, which is the high sodium. So attributing death to diet, precision counts. Assumption that exposure-outcome relationship is causal is often made. Strong evidence from randomized clinical trials, though, is not available. Confounding bias could be substantial. Are the 10 factors the right set, those 10 things that were listed? Things not included that Dave lists are trans fat, sugar, and potassium, but I would also add in dietary fiber. How dietary factors are interrelated and modified by each other, reasonable to assume that factors are all additive to affect 70% of deaths. It's just not possible. The findings reported by Micah et al. Appear to correct, but the reduction could be 30 to 70%, a pretty large window. So here we have some discussion now that he's moving into that there's evidence, some of the evidence for health decision-making moving beyond just randomized clinical trials. Thomas Frieden in the New England Journal of Medicine in 2017 pointed out that a core principle of good public health practices is to base all policy decisions on the highest quality scientific data. And then he further on goes to say the use of randomized control trials and alternative, sometimes superior data sources from the vantage point of public health illustrate the key limitations of randomized control trials. There's some true limitations. If you're looking at something that takes years and years and years to develop, you have to worry about compliance to the food intake interventions. It's not really feasible to perhaps put someone on a particular diet for 10 years in order to observe fracture risk relationships. Another thing that Dave wanted to point out, and we had a great speaker prep call a couple weeks ago, and I'll just give this a moment for you all to digest this. This is a relationship where the divorce rate in Maine is indicated in red, and the per capita consumption of margarine is indicated in black, and you notice that they kind of pace together. So if you live in Maine, perhaps you should avoid margarine to preserve your marriage. I also saw this same thing presented to me as early as high school. I had a professor actually show banana imports and their relationship to suicide rates and talked about the differences between causation and correlation, something that we all need to be quite observant of when we conduct science and reviews. So, moving on to thinking about correlations and causation. Dave was recently involved in the cancer research that resulted in the proposed carcinogenicity of consumption of red meat, where the working group within the IR had reviewed 800 epidemiological studies to investigate the association of cancer consumption and red meat or processed meat across many countries and several continents with diverse ethnicities. In red meat, they had 7 of 14 cohort studies, and for processed meat, 12 of 18 cohort studies that indicated there was a risk. Absolute risk, the lifetime risk of colon cancer among vegetarians is 4.5%. But for people who eat 2 ounces of meat per day, 5.3%. The IARC identified hazard, but not the degree of risk. The statistical significance in human studies was determined by the risk ratio. There was no systematic literature search done. The quality of individual studies was not evaluated. No meta-analysis. The Lancet Oncology actually had a summary that cited a 2011 meta-analysis by one member not mentioned at the working group meeting. Virtually no review of epidemiological studies by the rest of the working group that did this review. This is the relationship shown between meat intake and mortality of an NIH study. In this study, published in 2015 with Dave Klurfeld as one of the authors, showed that all other mortality, when you combine, and you can see the long list here: kidney disease, liver disease, COPD, Alzheimer's, ulcers, diabetes, infection, HIV, and tuberculosis, outranked on the red meat mortality, just about everything that was going on. So there were 2 randomized control trials on colon cancer. One was the polyp prevention trial. The other one was through the Women's Health Initiative. The polyp prevention trial had 950 subjects approximately per group with polyps removed and a 3-year follow-up. A low meat diet and also with whole grains and legumes was what was put into the study. There was a publication of the study in 2000, and the risk ratio of recurrence was 1%, so nothing remarkable, right? Women's Health Initiative almost 20,000 individuals on a low-fat, low-meat diet, and 29,000 on a usual diet for up to 9 years. And that was also published with a relative risk of colon cancer of 1.08. Again, not a lot. So when is a carcinogen not a carcinogen? And this was published in June 2016, basically talking about a month rarely passes without something being declared unhealthy or carcinogenic. Often the WHO, International Agency for Research on Cancer, is at the center of such pronouncements and is duly rounded on to explain the consequences. IARC, however, is not the only agency with the responsibility of determining carcinogenicity of products, compounds, or lifestyles. So this is, further on, they go on, the problem determining reliable findings when data are equivocal. And that there is equally clear need for standardized, internationally agreed on methodology for carcinogen effect. And until these objectives are met, carcinogens definition and regulation will continue to be the poor relation to the other. And so this is another reason why it's important not to equate margin consumption with your marriage dissolving, and also same thing with red meat and causing cancer. We've seen a lot of reversal in nutrition opinions, perhaps because of the fact that we have a lack of good randomized clinical trials on some of these chronic disease endpoints, where eggs and cholesterol, well, they were bad in 1984. I was just talking about this with someone yesterday. And in 1999, suddenly eggs and cholesterol, that's okay. And now we're being advised to eat butter. So the world continues to evolve and turn as day to day goes. But we have to keep in mind to use sound science to make decisions. So our key takeaways: nutrition research will not earn the same respect as other hard science fields until we accept the same rigorous standards for reaching conclusions. This is a point that myself, Dave Klurfeld, and many others have continued to impress upon the research community. Grading of nutrition recommendations should be done with existing processes like systematic reviews, meta-analysis, and especially GRADE. Uncertainty factors point to the need for precision nutrition, targeting based on differences in genome, proteome, epigenome, metabolome, and microbiome. Personalized nutrition sounds great, but it likely overpromises, and I would suspect is an indication that there's a lack of appropriate education going on within the nutrition community to the public about what the impacts of their research are and what they truly mean. One-size-fits-all approach is likely to fade away, however, as we continue forward. So Dave has this sign. I like the one where he has the scientists that go off the cliff instead, but here he says evidence 27 miles away. Implementation, though, is much further to go. So I leave you with that, and we can hopefully have caught up a little bit on our time for our panel discussion. Thank you.